Okay. Acid-base balance. Acid-base balance is the process of regulating the pH, the bicarbonate concentrations, and the partial pressure of carbon dioxide in body fluids. Primarily, acid-base balance is accomplished through the regulation of hydrogen ions through constant adjustments in specific processes. So, if you look at the surrounding things, almost everything has a hydrogen ion in it. So hydrogen ion is our acid. And an acid is a substance that easily, or maybe not always easily, but can release a hydrogen ion. And a base is the substance that takes up a hydrogen ion. So HCO3, or bicarb, is the most important base in our body. And then H2CO3 is carbonic acid, and that's the most important acid that we're going to talk about. CO2 is important because it's the CO2 and the water that combine to make H2CO3. And we'll talk about how does that happen. And then when H2CO3 breaks down, it breaks down into a hydrogen ion and bicarb. Or it can break down into water and carbon dioxide, depending on where the breakdown is occurring. So the processes that regulate acid-base balance are the things that cause acid production or intake of acids. So metabolism produces acids. So obviously we're producing acids all the time, because just the normal everyday function of the cells produces acids. The two primary acids are carbonic acid, which is the H2CO3, and then metabolic acids. And we're not going to worry about the chemical makeup of metabolic acids. But carbonic acid is important because it's regulated a lot by the respiratory system, whereas metabolic acids are regulated more by the renal system. So the first process is acid production. Second process is acid buffering. We're going to talk more about acid buffering. But acid buffering, the intent is to minimize changes in pH by taking up or releasing hydrogen. So hydrogen, again, is the primary acid or regulatory. We decide hydrogen stays or we decide hydrogen goes in order to control our pH. And so we want the pH to stay within a fairly narrow range. And if you remember your chemistry or wherever you learned about pH, blood, 7 is neutral, but blood is actually slightly alkaline. So normal ranges are 7.35 to 7.45, and that's where we like to stay. There's a wider range that's compatible with life, but it isn't a huge range by any means. And then the third process is acid excretion. So how do we get the acids out of the body? So those are some of the things that we're going to discuss. I got interrupted and somebody and I messed up my thing. So anyway, I don't know how this is going to turn out for you. Okay, so where was I? I don't remember. So I'm just going to move on. So the pH is maintained by homeostatic mechanisms. So they read the hydrogen ion levels essentially, and say, oh, we're in acidosis, we need to do this, or we're in alkalosis and we need to do the other thing. So sources of acids are retention of carbon dioxide or retention of metabolic acids from metabolism. And then we have the two types of acid-base disturbances, and then each one of those can occur in respiratory or metabolic. So how do we control it? Well, I've kind of already talked a little bit about some of these, but I want to talk about buffer systems. So we have buffer systems help to control. We have the lungs and we have the kidneys, and I've kind of talked a little bit about lungs and kidneys. So what are buffers? Buffers attach to or release hydrogen ions to maintain the pH. The primary buffer system we're going to talk about is bicarbonate carbonic acid system. We're not going to be too concerned right now about phosphates or proteins. So buffers are the first line of defense against pH imbalance, and the lungs are the second line of defense, and then the kidneys are the final line of defense. So again, buffering minimizes changes in pH by taking up or releasing hydrogen ions. Usually the buffer systems are pairs of chemicals, which the one we're talking about is the bicarbonate carbonic acid pair. So usually when we have bicarbonate carbonic acid, the ratio is 20 bicarb molecules to 1 carbonic acid molecule. And the body works to retain that ratio. So the bicarb is going to buffer the metabolic acids by combining with the hydrogen to form carbonic acid. Now this might seem counterintuitive. If we have too much acid, why are we forming another acid? Well, the idea is that carbonic acid is easy to disassemble and get rid of. So bicarbonate combines with the hydrogen that the metabolic acids release and forms carbonic acid, which then immediately is transported, rather quickly, considering we pump 4,200 mils of fluid a minute, goes fairly quickly to the pulmonary system. Where, remember what happens once it gets to the pulmonary system. It immediately is broken down into carbon dioxide and water. So now we no longer have an acid. We simply have carbon dioxide, which is going to be exhaled, and water, and we can always use water. And so that process is continuous. And so one of the reasons for the high ratio of bicarbonate to a low part of carbonic acid is because we're going to make more carbonic acid, which is going to alter that ratio for the shortest period of time until we change that. So we're going to keep that pH balance. If we happen to have way too many metabolic acids, then too much bicarb is going to be used up. And then we're going to have acidosis because we don't have enough bicarb to balance the amount of carbonic acid that is being created. So when we have acidosis, remember, we're trying to get rid of that carbon dioxide because we're trying to get rid of that carbonic acid. What's the best way that we get rid of carbon dioxide? we get rid of it by exhaling. So if we're going to get rid of excess acids, one of the best ways to do that is to increase our respiratory rate, because we're going to exhale more carbon dioxide and hopefully create a balance. So that's kind of how the respiratory system can compensate for metabolic acidosis, and we'll kind of repeat that later. But if too much bicarb gets used up, now we have too many acids, whether it's carbonic acid or whether it's metabolic acids, and we have acidosis. If for some reason we don't have enough metabolic acids, we're not breaking anything down, which is really kind of hard to imagine, but if we have too few metabolic acids, then initially carbonic acid will break down within the body, not in the pulmonary system, but just within the body, to release its hydrogen, to try to maintain that balance. But it's limited in what it can do. There's only so much carbonic acid available to create, and so we're going to have too many bicarbs floating around, and we're going to have alkalosis. So I hope that kind of makes a little bit of sense. So you kind of start to get an idea of how the systems work together to create an acidotic or an alkalotic system. So I've already talked about the lungs. So the buffer systems, they react immediately and continuously. The lungs are the second line of defense. So if I have a buildup of carbonic acid, the lungs are going to take care of that fairly quickly, provided there isn't a disease process that interferes. So think about the goal of the lungs in maintaining acid-base balance. If the goals of the lungs are to excrete carbon dioxide because of its potential to be an acid, what kind of things are going to keep the lungs from excreting that carbon dioxide? So hopefully you've written down things like pneumonia, COPD, even heart failure, because we have decreased perfusion to the lungs. So these are, we block the alveoli with fluid, or we trap air in the alveoli, or whatever. We're preventing the excretion of the carbon dioxide. So the carbon dioxide is going to stay in the system. So anything that causes carbon dioxide to not be excreted is going to cause respiratory acidosis, because we're retaining that carbon dioxide. Okay? And we're going to talk more about that in a minute. And then we have the kidneys, which are the slowest to respond. They are going to excrete or retain the hydrogen ions, or they're going to excrete or retain bicarb. So we have to excrete those acids. So carbonic acid excreted from the lungs, metabolic acids excreted from the kidneys. So we're going to see changes in the respiratory rate and depth to alter the amount of carbon dioxide that's excreted. So if I want to get rid of more carbon dioxide, what do I need to do? If I want to get rid of more, then I need to increase my rate and or depth. The deeper and the faster I breathe, the more carbon dioxide I'm going to get rid of. If I want to retain carbon dioxide, then what do I need to do? And I'm sure you've already figured it out. I'm going to have to slow down my rate or decrease my depth, or both. So the slower I breathe, the shallower I breathe, the less carbon dioxide I'm going to get rid of. So think about what kind of things, it could be medications, it could be disease processes, are going to cause the breathing rate and depth to get slower or shallower. And I think the first thing that comes to mind is narcotics. Anything that depresses the central nervous system. So obviously this could include trauma to the brain. Anything that affects the respiratory center and causes it to slow down. So if I want to change the rate of CO2 excretion, I have to change my breathing. But remember, those chemoreceptors aren't just monitoring levels of CO2, they're also monitoring levels of hydrogen. And hydrogen is my acid ion. So metabolic acid changes are going to alter my respiratory status because I'm trying to adjust that pH. And this is compensation. So we have respiratory compensation for metabolic acidosis or alkalosis. We can't excrete the metabolic acids through the respiratory system because they're not gases. They can't be excreted as a gas. But I can excrete more carbonic acid and decrease or increase my pH a little bit. Then the renal system excretes the metabolic acids and or bicarb depending on what it's needed. Hydrogen ions are taken from the metabolic acid and excreted, while bicarb is retained in the event of metabolic acidosis. So if I have too many hydrogen ions, then I have acidosis and I need to get rid of those. If I am unable to excrete enough hydrogen ions through the urine, then I'm going to have acidosis. But the process in the kidneys is that the hydrogen ion combines with ammonia to form ammonium, and you don't really need to know this for the test. It's just maybe helps with your understanding. Because where does that hydrogen ion go? It's an acid, so we don't want to excrete acids through our renal tubules. It would destroy them. So what happens to that? So it combines with ammonia to form ammonium, and then it's excreted. So ammonium doesn't have any acidic properties, and it's not going to cause us any damage. It doesn't affect the pH of the urine or anything. If we have too little metabolic acids present, then the kidneys will secrete less of the hydrogen ions, or they're going to retain more of the hydrogen ions, however you want to look at it, and secrete more of the bicarb. And kidneys can also compensate for respiratory disorders by excreting hydrogen ions when the carbonic acid accumulates, or conserving hydrogen ions when carbonic acid depletes. And again, it's going to restore the pH, but we're going to see other problems. Other things are going to be affected. So that's kind of how it works, I guess. So how do we measure it? How do we know that our patient has acidosis or alkalosis? Well, obviously we can look at symptoms. We can tell if the patient has the potential to be going into or out of one. We can think about what's going on. Obviously we know a patient with COPD or pneumonia is going to be at increased risk of respiratory acidosis. A patient who is hyperventilating, increased risk of respiratory alkalosis. So the respiratory is fairly easy to see. The thing is, we have to decide, we have to look at, is what we're seeing in the respiratory system a result of a respiratory acidosis or alkalosis, or is it compensation for a metabolic problem? Because that's what's going to happen. So, you know, we want to keep those things in the back of our mind. So we measure acid-base balance by taking ABGs. So ABGs are or arterial blood gases. That's why we have the gas picture. I know. So the normal pH, 7.35 to 7.45. We're also going to look at PCO2, which is the respiratory component of the ABGs. It's measuring the amount of carbon dioxide that's dissolved in the blood. In other words, it's kind of measuring the ventilatory capacity of the lungs. As a general rule, well, I mean, as a fact, actually, when looking at ABGs, the CO2 and the pH are inversely proportional. Meaning, if I have a low pH, I will have a high PCO2. And why is that? I think it's fairly easy to see that CO2 is an acid, and acids are going to drop the pH. Now, as far as telling us about acid-base balance, the PO2 doesn't really give us much information as far as acid-base balance. But it can tell us or help us identify the cause. So that if I have a low PO2, does that lead me to think that I have a respiratory problem that's causing it? Just something to think about. Bicarb, or HCO3, is the renal component of ABGs. It's telling us what's happening with the renal system. Bicarb and pH go the same direction, because if I have a high bicarb, which is a base, it's going to build up the pH. So it's going to increase the pH. So remember that acids lower the pH and bases raise the pH. So your pH and your PCO2 go in opposite directions, and your base and your pH go in the same direction. Now, base excess we're not going to worry too much about. It helps the primary care practitioner determine things, but it's really beyond our scope. So some of the things patients need to know would include patient teaching on the discomfort of the test, why the test is being done. It's a painful arterial stick, and of course it's being done to help us find out, how to treat them better. We always want to perform the Allen test, and I think I might have showed you the Allen test in cardio, where you have them squeeze their hand and you occlude both the radial and ulnar arteries, and then open their hand and then let go of the radial, and we should see a pink return. That just tells us about collateral circulation, because if we stick the radial artery and then it spasms and causes loss of blood flow, we don't want to cause a patient to lose their hand by doing a simple test. Well, it's not really that simple, but anyway. Note the amount and the method of oxygen. This usually needs to be reported in the request for ABGs. So are they getting 2 liters per nasal cannula? Are they on 50% per non-rebreather mask? What are they getting? Are they on a vent? Because, the ABGs, we're going to expect somewhat slightly different depending on the type of device. Avoid doing the test after the patient has done it, immediately after the patient has done some type of activity. Obviously, this is going to alter the results. If they are short of breath, they may blow off more CO2, or they may build up more acids because they've done some type of activity. So we want to avoid that. Specimens are always placed in a heparinized syringe, and you expel the excess air, place it in ice, and take it immediately to lab. Because we have accessed an artery, we want to make sure that we hold pressure on that site for several minutes or longer if needed.